So what a fascinating session we had before with such interesting data. And what I'm going to talk about is sort of complementary to what we've heard from beautiful work by so many, much of which came from cohorts of Li-Fraumeni patients who were identified from childhood cancers. I'm an adult oncologist, and what we've been seeing are more people who've begun to have their p53 mutations found in the course of the multigene panel testing. So I think it's no surprise that they look a little different. That's what we're going to discuss, if we can get this to go forward. There we go. So just to remind us all about how this came to be and all the giants who are in the room. And Kim Nichols herself was the first author on a paper that looked at the spectrum of tumors that are part of Li-Fraumeni syndrome. But in the early years, and I definitely was here for those, testing was single gene testing. So we would test after 1990, when BRCA1 was mapped and p53 was identified in Li-Fraumeni, we would test people over time in the breast cancer world for BRCA1 and 2, and then after Jeff Weitzel showed that mutations were more common in younger patients or people with triple-negative breast cancers we were testing, we would test someone for p53 only if they looked like Li-Fraumeni. So we were very selected, and looked like Li-Fraumeni meant, as we saw before, meant their family history met some criteria. But we knew from population-based series that there were always a few women with breast cancer who had a p53 mutation and just didn't make criteria. So we know that these are rare. We know there are lots of rare tumors that are part of Li-Fraumeni from lots of work from people in this room. And we've seen the penetrance estimates that have been very high in the past, and they are very accurate for those populations. But we'd started to see families that looked a little different. So here's a classic Li-Fraumeni family, and we've seen examples of these, so I won't spend time there. We've had criteria developed over the years, primarily from the French group with their very systematic studies of patients with pediatric cancer. We heard from Laurence about this group, and they systematically tested children with cancer, as did Louise Strong at MD Anderson, so they were not subject to selection among the children. Just having childhood sarcomas should be enough to get you tested for Li-Fraumeni, but then building out the families from there, in that approach, you do miss families who might not present with a childhood cancer. And of course, we all expect in Li-Fraumeni that childhood cancer should be very common. The idea for the panel testing, just to give 2 seconds, came in the U.S. first from the work of Mary Claire King in BRCA1 and 2. Really, but in this case, she was the first to look at a series of ovarian cancer patients, or ovary and related sites, who, independent of family history, and just to sequence for BRCA1 and 2, which you can, I don't know if there is, yeah, which are the large portions of the circle, and then to look across DNA repair genes, including TP53, that's the yellow at the top, and you would certainly not have expected to find germline TP53 mutations in a series of ovarian cancer patients. Ovarian has never been prominent in Li-Fraumeni. But there they were, and at the bottom you can see that these were women who had no family history of other cancer to have suggested they might have mutations, and they weren't all young at diagnosis, as we tend to expect for people with an inherited predisposition from the Knudsen-Strong modeling. But there they were. Now, there may be debates about were they pathogenic or not, but at least the concept was there. And in the U.S., this came at the same time that the court said that individual testing labs could not could not patent their testing, but could not become monopolies, that there had to be more room for other labs. And the fact of panel testing allowed that to happen much more quickly. So now in the US, genetic testing laboratories are multiple, and testing costs, of course, have come down, and we now pay hundreds of dollars for analysis of multiple genes, where we used to pay thousands of dollars for a couple of genes. So that this paradigm has become largely the standard of care. Now, not exactly. You can still get more limited testing. You could, in theory, test only for p53, and there certainly are people who exclude p53 because they don't really want to find it, but that's largely only true in academic centers that have sort of personalized panels. Otherwise, testing is more and more by these multi-gene panels, and TP53 is part of the gene list. And multi-gene panels range now from something like 25 to, I think, 140 from Fulgent. And the question is, are these just intervals on the way to more complete genetic testing? But that's for another day. So once you start doing panels on patients, the majority of whom, in fairness, are people concerned about breast cancer risk. They're more women. They're more related to breast cancer, but there are people being tested for colon cancer, for ovary. That's now in the guidelines, all ovarian patients, and certainly still patients for rare family histories. But even in those cases, June Kamahara, who runs our clinic, does panel testing in the children. So now you might find multiple mutations, and that question came up before. Here's a family where the father has the BRCA1 mutation and the mother has the TP53 mutation, and there's the daughter who has both, and neither of these families looks particularly suspicious for either one of those mutations, and she has had breast cancer and sarcoma in her 20s. It's hard to say that's worse than one might have expected for either gene alone, but it certainly isn't better. And Jeff is going to talk about the mosaicism, clonal hematopoiesis, families that don't look like they should have inherited cancer risk at all. But these days in the US, even if women don't exactly make criteria, having had a breast cancer diagnosis at 61 and a daughter, this woman might have been interested in undergoing genetic testing, and she was found to have a P53 mutation, which her children did not inherit from her. And of course, since she was 73, there was no chance of testing the parents. And here's Jeff Weitzel's analysis of her eyebrow pluck showing that she is, in fact, mosaic. This is not a germline mutation, and he'll talk about that more. And so we also have seen confirmed germline P53 mutations with much later onset than before, and this was raised in prior talks this morning. So what we did in our group was to look at the data from a single testing laboratory. In this case, it was Ambry Genetics Labs who shared their data with us. And we wanted to ask, of these people having testing through the labs, are they going to look different? Now, you'd expect that they would look different because most of them will not be for childhood cancers. So these will be people who've lived through their childhoods without getting cancer the vast majority of the time. But we looked at their age at cancer diagnosis, age at testing, the LFS core cancers, PD cancers, and breast cancer phenotype because of the previous data from our group and others that most of these tumors might be ER positive and or HER2 positive. And we tried to look a little bit at genotype, phenotype, and I only have one slide on that because we're looking at that separately now. So we looked at these probands. So here's a huge number of probands, great numbers. We start at the top there, but over time, these will come down. So there were some exclusions. We had people who had had single gene testing and then multi-gene testing. We left them out. We left out people who had a known pathogenic mutation in the family. We left out people who never provided any cancer history to the lab. You're supposed to provide some, but there's no rule about how complete that needs to be. And people where they forgot to list their gender. We left out people where we thought they might be the mosaicism that we'll talk about. So for this, we just set the allele frequency bar at 25%. I think Jeff will tell us that we don't know where that bar should be. Is it 49%? Is it 40%? Is it 30%? I don't know. But for this, we put it at 25. So you should keep in mind that we don't exactly know when you're looking at these numbers. And we left out a few others where we really, they had other mutations in other genes. So we were hoping not to find too many. And we thought most of those P53s might not be pathogenic. So we ended up with 35,000 individuals who had multi-gene testing and 3,000 single-gene testing, and we used Sharon's ACMG criteria. So the things to remember in this, the strengths are a large cohort. So there is pretty extensive clinical data. The laboratory went back to as many patients as they could to try to confirm the family histories and to expand them because people are often limited in what they submit, but we were certainly not able to go back to everyone. I think we confirmed in about a 54% response rate, and you can see that's variable. The limitations are that this is largely a panel of Caucasian women in the U.S. with breast cancer, not all, but certainly most, and that we can't fully clarify the mosaicism or the family history, and we don't have pathology on all of them. So it is what it is, and it's not what it's not. So we had demographics, we had some personal medical history, we did some follow-up, and we had some details of the cancer diagnosis as best we could on the patients and the family history. And I'm not going to go through the statistics, but we'll provide them if you want. So the demographics of the data set, you can see, I will have to do some of this. Wait a minute, maybe I can do it here. There you go. So here you can see the gender distribution. So very few men comparatively, and more proportionately Li-Fraumeni positives in this. So it just takes more to get them in, I guess. But you can see what the numbers are like. The age distribution for testing here. So we do have some young patients, but not very many, relatively speaking. You can see, whoops. Oh, well, that's interesting. I didn't do that, I don't think. Or maybe I did. I hate to waste the time, but there we go. Anyway, so you can see the distribution, and at the bottom, the cancer history group. Here, just looking at males and females combined, you can see the prevalence of mutations. So in the single gene group, 4.1% with pathogenic or likely pathogenic TP53 mutations. In the multigene panels, 0.2%. So 0.2% is, right, 2 in 1,000, so not too far off from the range that we heard from Maria Isabel and Tom. And you can see the variance and the negatives just for balance, and there was some difference in the panels that were ordered. By gender, I just put this in the females, and in the males had a higher prevalence in this series, so it tells you something about who's getting testing. I don't think it tells you anything really about that there might be a higher prevalence in the males, and I don't know why this migrated up, but it was certainly significantly different, both in the single gene and multi-gene panels. So here just to say there were 118 distinct alterations in the 222 positives, 57 in the 96 multigenes, and 80 in the single genes. Most of them were found only in one or the other group, but these are obviously not huge numbers. There were variants, and then there were dominant negative missense mutations as the most common type in both cohorts. And Thierry has tried to segregate these mutations into different types of mutations. We tried to look at that in here a little bit. So what did we see? Well, by age of cancer diagnosis, no surprise, the red is the single gene and the blue is the multigene. And you can see that for females, there clearly was a significant difference. So people in this cohort were people who had lived through their childhoods largely not getting cancer. That's why they were getting tested. Most of them had breast cancer. And here's the males with an even larger difference. And this is the data for breast cancer, and you can see that that difference is largely maintained, that the median age at breast cancer diagnosis in this cohort was 40, and 33 in the single gene patients. So younger in those patients, and that's a median, so there's a range around that, but that's certainly different than the numbers most of us carry in our heads for who should be having Li-Fraumeni, or who we're thinking about for Li-Fraumeni, where we're worried. And if you go down here, you can see that for the multigene patients, 53% were over 35 and 22% were over 45 at the time of their diagnosis with breast cancer as their first diagnosis, and 39% and 9% in the single gene patients. If you looked at family history of LFS by cancer type, it's pretty similar. So here the yellow are the single gene patients with a family history of Li-Fraumeni. That's what they probably were tested for. And then here are the single gene with no family history of Li-Fraumeni. But they had single genes, so either they were unusually young or had some other feature, and the older group getting the multigene panels turn out to be later, and the same significant difference for men the same way. So this is just true, and here it is for breast cancer, pretty similar. So what does this say? This is not meant to say that we're redefining Li-Fraumeni phenotype. Here for Thierry is just the distribution of the types of mutations, which is not that different group to group, and we have more data now from Ambry to try to look at this more specifically, so we'll see where we are next year at this time. We had those ready. So I think this is just the group that worked on this, which just came out in JNCI a few weeks ago. And led by Humarana, the geneticist in our group now who's interested in working in this area, and it was all adults. So if you're looking for June, that's why she wasn't on this one. But I think that the issue in the US is panel testing is by far now the most common way that testing is being done. So presumably we're having some evolution as people move from having single gene testing to multi-gene testing, and this kind of analysis will soon, I expect, absorb the majority of childhood cancer patients as well. We won't have so much single gene, but we will have to still think very much about the issues of mosaicism and how that's being defined, about the specificity of the mutations that we're finding. Are they pathogenic or not? The usual conundrum that we all have. And then the management issues for these patients. So I have to say, I do talk to my patients now when I see people who find their mutations in multigene testing in the context of a breast cancer diagnosis and tell them that for those patients that there may be some penetrance differences and that it may not look quite the same as it does for people whose family histories are found in the course of a childhood cancer diagnosis. But based on work from Kathy Schneider years ago, we know that people are generally not very accurate about family history. Family cancer history particularly, they're often least accurate about the kinds of rare diagnoses that we see in Li-Fraumeni. People may not know what that there was a childhood cancer if someone passed away before the surviving family members are there. That's certainly what we saw in our data. And people, even in adults, people are not very good about the abdomen. It could be anything. Usually should be colon cancer, but it took a long time for people to realize they were missing ovarian cancer for the BRCA patients. And you can imagine that people who don't know what a sarcoma is may have a very hard time telling the difference between a sarcoma and metastasis to a bone, for example. So family history accuracy is an issue here, and it's why broad testing is being done. So that is my social commentary on all of this, and I hope that it's a little more hopeful in that view. I do think it says that in our efforts to define penetrance for Li-Fraumeni that we have to look more broadly than we've been before, because we've had some selection bias in that we've looked at families who were the most dramatically affected in the past, and it's encouraging to me that it may not be always quite so difficult. It may be that it's the modifier genes that are the difference. There certainly could be other factors as well, but we should at least hopefully think more broadly about what is the penetrance of these mutations. And that's all I have to say. I'll make up some time.
So, any questions for Dr. Garber?
Everybody wants to go to lunch, and that was nice. Okay.
Well, and so Judy, this is obviously a great observation, and I think it's something we're going to see more and more of, the use of the multigene panel test and how we understand this. This is a great first step. We really appreciate that. Thank you. So yes, Gareth Evans.
So I think, this whole concept of penetrance has been raised, and this is what really throws it into sharp focus, is seeing this proportion of mutations. And I think the difficulty is, unlike BRCA, where we've been able to already develop substantial prospective cohorts,
right.
I think they're going to be very different penetrances for different variants within P53, which is going to really complicate things. And I think the other complication is, as soon as we find a P53 mutation, we're going to do a whole body MRI scan, which has a huge prevalent effect at finding tumours that might not have presented for a number of years. So I just don't think there's going to be any easy shortcut to finding, an accurate penetrance for these, and it's going to be very dependent on the circumstances of how you ascertain the family and everything else.
I totally agree, and I'm afraid, I would like to be reassured by these numbers, but I'm fond of saying that we've got many families who were low penetrance until they weren't, and didn't look much like Li-Fraumeni until suddenly there are sarcomas and brain tumors and all kinds of things that you didn't expect. So it's not that we can be so reassuring about this. But I do think it means that hopefully there's a bigger spectrum of mutation, of penetrance than we thought.
Yeah.
Arnie.
You talk about the BRCA1, but
I'm sorry.
nothing has been really said about the CHEK2. I tested positive for the CHEK2 mutation, pathogenic. And then shortly after that, they do a CT scan because they're getting ready to do a double mastectomy and find out I have renal cell carcinoma. I also had a hysterectomy at 25 from endometriosis. So the CHEK2 mutation, not a lot's being said about that. It seems like the BRCA1, BRCA2 comes up, but what about the CHEK2? Have y'all looked into any of that?
So I think you're right that this kind of approach that we took here to look at P53 is part of how we have to look at less common genes too, like CHEK2 and ATM, all these genes that we now realize are predisposition genes, but where we don't know the details the way we do for, BRCA1 and 2 have been around for 25 years. CHEK2 in a very specific way for quite a while, but it has to still be sorted out. So I think in this meeting there's a lot of focus on P53 for obvious reasons, but that doesn't mean we think we've solved the other problems.
Dr. Levine.
It seems to me that we can see an interesting problem coming up that was articulated by you before. Just to put a quantifier on it, there are about 220 positions in the DNA binding domain, 406 different missense mutations. And that is the challenge if penetrance is an issue. But penetrance is an ill-defined thing right now, and I would suggest that we get together as a group and try to ask the question, what are the genetic modifiers and what are the environmental modifiers? Now, the environmental modifiers are actually pretty well known from the fact that P53 responds to a number of environmental stresses, and some of those stresses, or many of those stresses, are the causes of cancer. So I think that the docs have to have a protocol where they ask questions of people about their past history and exposures and things to environmental things. And that can be put together, although it's never going to be perfect. The genetic modifiers, I think, are something to really start to work on. As everybody is now starting to present, we've got large databases, but they're terribly incomplete with regard to second genes and third genes. And we now have to make a list of the ones that we need to get. So when we report a patient, for example, I'm going to give a talk about this. When we report a patient who has a late onset, unexpected kind of tumor and is got a P53 mutation, we really want to know something like the HLA types. We want to know something about other kinds of genes which are known modifiers in cancer. And so I think we have our path in front of us. We just have to define it very clearly and unfortunately get enough money to actually do it. I think those are the challenges.
We agree.
Dear mouth to God's ears. All right.